Welcome, and thank you for joining Speak Up for SaferCare. Speak Up for SaferCare is a product of SaferCare Texas, the patient safety division at the University of North Texas Health Science Center in Fort Worth, Texas. Our mission is to challenge traditional thinking to eliminate preventable harm. Speak Up for SaferCare illuminates gaps in care, process, or design that lead to preventable harm in all healthcare settings. I'm your host, John Sims, and the director of SaferCare Texas, and joining me is our co-host, Leanne Cunningham, Strategic Operations Assistance Director.
Good afternoon, everyone.
Today's guest is Dr. Jeff Beeson, Managing Psychological Stress During Emergencies. Dr. Beeson is an emergency physician with over 30 years of interprofessional practice, starting as an emergency medical technician working in rural settings, a paramedic and registered nurse in emergency departments and air medical programs, to then becoming an emergency physician whose passion lies in improving healthcare systems. A recognized leader in integrated healthcare delivery focused on interprofessional teams in top of licensure practices that are changing the landscape for population health. Dr. Beeson, thank you so much for joining us. So we've all faced emergencies to some degree, and emergencies in healthcare settings are a little different than emergencies in other settings, but they often occur without any kind of warning. How do you approach life-threatening emergencies?
Well, I think it's really a personality trait that certain people have and don't have. There are individuals that really have to have things planned out. And then there's others like myself that we don't plan well. So we prepare for anything. And I think that is the key to any type of emergency type of response or emergency care providers, really the preparation, because you don't know what's coming in. And most often the times you don't get a heads-up warning. There was an old book written by a surgery resident out of Denver General back in the early 80s called The House of God. And Samuel Shem wrote in there, the first rule in emergency is to take your own pulse. And I remind people of that all the time. I mean, when you see things or you feel things are getting out of control, the first thing you need to do is check your own pulse, calm down, and then sequentially move through the systems and the steps that need to be taken.
Dr. Beeson, I've known you a long time. I knew you as a student, and you truly epitomize healthcare professionalism. I'd like to ask you, I know that you report on disasters like hurricanes and tornadoes. As a leader, how do you first manage your own stress? And secondly, how do you help others manage theirs?
So in my role as working with our state's search and rescue teams and go into disaster response, if that's kind of, I guess, what you're asking about. It's amazing the amount of time spent in preparation, preparing. In those types of emergency response, everything is spelled out in the organizational structure, and that's an important piece. So it doesn't just happen by accident. I mean, we train hundreds of hours a year in preparing. And I think that's the key thing that we often take for granted. I mean, from a medical standpoint, my primary responsibility are the team members. We have 3 teams just on Texas 1. When you had Texas 2, I mean, you're talking 500 to 600 providers.
Oh, wow.
And so on an annual basis, I spend most of my time making sure that those folks are healthy and well in preparation for deployment. They're firefighters, engineers, nurses, doctors, all kinds of stuff. And so making sure they're healthy and well. And then from a logistical standpoint, is the cash management is huge when you think about the different disciplines from rescue to search to logistics management to planning. I mean, everybody has their own cache of equipment, and it's $1 million worth of equipment. And we literally go through it multiple times every year. And that's really the key to any disaster response is really the preparation before the disaster occurs. And then knowing what everybody's role is going to be when disasters happen. We see that now, and you can go to any large academic trauma center, right? And especially in teaching hospitals, you will see different posters or things on the wall that tell you, depending on what position you are around the patient, what your roles are in that. And that's kind of what we do, right? So we're responding to a disaster. The disaster is much more than a single patient, but we know what everybody's role is. and I have trust and faith that my colleagues are doing their job, so I don't have to worry about it. And the same thing, they know that I'm going to do my job, and so we work collaboratively.
So you do feel like it minimizes stress?
Yeah. The stress is really the mindset. I mean, if you don't get a little excited or nervous, then something's wrong with you. I mean, that's the typical. I mean, that's what our body is designed to do when you think about the fight or flight response of what catecholamines do. But we do know, especially in emergency professions, emergency responses, that over time there is a fatigue to that stress. And it's not really the stress goes away, that our threshold for stress changes.
Could you give me an example of what patient harm might happen if that stress isn't managed?
So if you this is seen in law enforcement, firefighting, a lot of public safety realms. You have to practice like you expect to respond. And so that's one thing I see and worries me often in medical simulation is that we focus more on the skill of performing some intubation or IV start and less about the whole environment of when you're going to perform that skill and the critical decision-making that goes into that. And so I think it's very important when we are running simulations and we are doing things is that we do it exactly like we are going to expect some student, doctor, nurse, whatever, to respond in that time. And so that does take stress out. The first time you do a simulation and you really are preparing to perform it, I mean, the more realistic, if you set the expectations, I want you to do everything you're going to do in real life, the pressure goes up. And so then when you're actually in that situation, it becomes second nature, and it's not like the first time you've done that.
It just kicks in.
Right. So in our search and rescue, we have 3 teams. In every third year, you have an operational exercise. The other 2 years, we actually have a mobilization exercise. And so when the pager goes off or you get the phone call that there's a disaster, there's a sequence of responses. We're all over the state of Texas, and we have to be at College Station within 2 hours, and we have to be out the door in 3. If military is sending a jet and we're going international, it's got to be loaded in 4. So that just doesn't happen, right? So when you do these mobilization exercises and people get down there, they check in, they know the processes, they get their equipment ready to go, then when the actual no-notice event occurs, the stress is down because you've done it before. And so I think that goes into the mindset. And the second thing is you know that no matter how much you plan, something's not going to work. Right, and it's how do you work through the events when something's not going as expected. In freaking out, that goes back to Samuel Shim checking your own pulse. That's the key thing: remaining calm and sequentially moving through things. And there are people that have that innate characteristic, and there's others that don't. And those are usually the people that know exactly what area of medicine they don't want to go into.
Well, Dr. Beeson, that's an interesting point. And I want to talk a little bit about that. But first, I want to go back to what you mentioned earlier about checking everybody. Everybody's wellness, are they ready? That speaks to human frailty. And we've talked about that on a couple of our episodes. And that's, there's lots of things that people go through in their their interpersonal lives that when put in an emergency situation, it's going to affect how they respond. And so I'm glad that you do that with your team. The other thing I wanted to share is I remember a time when there was a physician. That's why I laughed when you said some people know that they're not supposed to go into that profession. We were doing a procedure. And there was a physician doing the procedure. It was a GI procedure, and it was in an intensive care unit. And there was a massive GI bleed during the middle of that. And he freaked out. We've got a whole staff of people there, and he freaked out. And so when I think about that, I just, the leader, whomever's leading, they've really got to check their own pulse, right? Because everybody else is watching them. If the leader is freaking out, it's like, we don't have a chance.
Definitely, that sets the tone of the team response. And so, in many resuscitations, surgeries, any procedure-based thing, I mean, it's just like being an aviator. There's a checklist. And so as many things as you can get into an algorithmic response, and you practice that on a regular basis, then it becomes second nature, as I said before. And I think that's an important piece. I mean, you think about advanced cardiac life support. I mean, ACLS is, not designed for the individual that does cardiac resuscitation on a regular basis. It's designed for the person that rarely, if ever, does cardiac resuscitation, so that they don't have to think. They can pull out that checklist and sequentially move down the steps. And I think we have often, misrepresented that. I mean, you look at, in healthcare, everybody has to have a CPR card. Well, there's no evidence that really changes the response. If you're an individual that does CPR on a regular basis, is that really what it comes down to, that you have some card that says you're good at it? No. I mean, it comes down to monitoring the quality when you do things, and so that goes to the training aspect perspective. When you're having those events, I mean, in the trauma world, we have morbidity, mortality, M&M conferences and reviewing things, and I think that's the key thing, that not only doing a response or doing things, but also learning after the fact and evaluating. We do it in the incident command world, and in the USAR response or any disaster response. We call them after-action reviews. So every event we have, every discipline goes through and summarizes what went well and what didn't work, both in your own specialty or discipline and also amongst other disciplines, because those are really the things that help you improve and get better for the next time you respond.
Exactly. You have to have a very strong culture for that to be successful, right? Because if that's done in a punitive, like, what were you thinking?
You do, and that goes to psychological safety.
Correct.
I mean, just like in any hospital doing a cardiac resuscitation or any trauma resuscitation, I mean, everybody in the room needs to understand not only their roles, but also they need to feel comfortable when they see something, even if it's not within your responsibility, but speaking up when you see those things. And that goes to, I mean, we have all been in environments with leaders, if that's what you want to call them, who are not open to suggestions. They know everything in more of a dictatorship style. And that's the culture that leads to bad outcomes and safety risks. And I tell folks all the time, I mean, when we're about to go out an event, I need everybody to speak up. I mean, if you see something, say something. If you're concerned, you have that little twitch, in your stomach, you need to say something. Because you may be seeing something or have a concern that the rest of us don't see. And so that open communication. And to your point, John, it's important as leaders that we take criticism well. And not, it's human nature to become defensive when people are pointing out things. And I see that more in people that are insecure in their positions. They really get defensive when they're insecure. So as leaders, we need to create a safe environment, and we have to be open to things that sometimes may hurt our feelings, and they may be wrong or indifferent, but it really letting individuals know that your perception is your reality, and we need to talk and work through those things.
Sure. And you need to have a shared mental model on what's the outcome. It's not about you. It's about the team. It's about the event and managing it well.
That's right.
Can you describe an event? And you mentioned that you're stressed at every one of them. It's how you manage it. But tell us one where maybe you didn't manage the stress the way that you've been accustomed to as of late. What was that event? How did you overcome it? And then what was the eventual outcome? What did you learn from it?
Man, you got to put me on the spot here, didn't you? So I think of safety is a primary example. So when we go on deployments, we have a safety officer. We actually have two safety officers, safety directors. But you're talking about a team of 100. And so when we get into certain responses, I mean, the system was designed for the rebel pile where you think everybody's going to be like you just saw in Florida working in one environment. That's not the vast majority of our federal responses in the country. They're hurricanes, tornadoes, wildland fires, where you end up wide area searching. So your team of 100 gets split up into, small teams of 5 to 10, and they're covering a huge amount of dirt. But the redundancies of safety, the redundancies of medical were not designed to support that kind of distribution. And so how do you work collaboratively? And so we had a hurricane response years ago, and it was like a disaster on top of disasters because in other parts of the country there was already things ongoing. And so,
I was wondering if you were going to talk about that.
yeah,
I do
and
remember.
so this is one example. So, the vast majority of our team, we have charter buses. So we have bus companies that we charter. And in this case, our typical charter bus was already all chartered out. So they kind of do the Uber-esque type of thing. They throw it out to the nation and say, anybody, you want to pick up this team in Texas and take them to Florida? And so this bus showed up. And, it's nothing that you'd want to put your family on, right? And so we're in such a hurry to get out the door, and then we're driving through horrible weather, and, half of us are in vans and trucks pulling boats and a variety of semi-trucks pulling our logistics team, and then you've got a significant portion of our team on this bus. And when we got to our first stop, where we overnighted waiting for the storm to come ashore, we had a serious conversation with our leadership. It's like, so would you want your family on this bus? And we all agreed no. And so then what would we do about it? And it came to the point you got to stand up and say, we're not putting anybody in this. We have to get another bus. And so those simple things, when you think about safety of the equipment, we take things for granted. And what do we learn from that? So we change now. So many of the federal teams, when you call charter bus companies, who work with local, highway patrol who do DOT inspections on vehicles, and so when those charter buses show up, the highway patrol's there, and they're doing a Department of Transportation inspection on there. And guess what? Now the bus drivers actually come in and get medical clearance, just like the other teams do. And so those kind of things that are unexpected, that really comes down to safety of a team. I mean, if that bus were to have a blowout or something the brakes would have gone out, I mean, over half of our team would have been, out of service, if not seriously injured. And so those things that are not medical, I'm a physician. I don't think of those things. But when you put the safety hat on, you start thinking about the risk to the team by the environment you put them in.
And that goes back to what you said earlier, see something, say something, no matter if it's going to slow us down. We, of course, here call it speak up for SaferCare, right? So, in the space of HSC and our mission to create and produce the providers of the future, how would you prepare medical students for approaching some of the things that we're talking about? Because they're gonna get out there, they're gonna be faced with uncertainty in emergent situations. What would you tell them?
So the first thing I instill, so I'm a faculty advisor for our osteopathic medical school here, and so the students that I advise when I meet and give them my opinion and guidance on things, it's really about letting them know that yes, you may be the physician, and you may be the captain of the ship, but you are not the crew of the ship. In getting them to change their mindset from the get-go, and you see this historically in various disciplines in graduate medical education, so residencies and other things. You see the culture in certain high-stress environments to be that very military-ish, very harsh, don't speak up. And I think ultimately that we have seen changes, at least in the last 20 years, in that, because that environment impedes that psychological safety and really suppresses people's ability to feel like they can speak up and say something. I also think it goes to setting the example is that, your profession often don't let that become your identity, right? It's a job, it's your chosen profession. It is really an art, something that you live, breathe, and do, but don't let it become who you are. You still have to have an identity, a personality, something outside of whatever your job or your profession is. Mm-hmm. And I think that really hopefully brings our providers, our physician providers, especially into the realm that working as a team, and not just creating the culture of it's okay, I want you to say something, but intentionally and purposefully asking, hey John, how did you feel that went? Did you see something? I do that when I was in the emergency department full time. That's one of the last things I would do when we would complete a cardiac resuscitation, and you're about to terminate your efforts because you've done everything, mm-hmm. right? I would go around the room and ask everybody, is there something we're missing, something we're not thinking about? What else should we do? And so it is partially me encouraging open communication, but it's also therapeutic for those individuals to feel like, we did everything that we could do. And you instill that in the next generation, right? Somebody instilled that in me. I have my mentors, and I think that's what you become as you go forward. The clinical aspects of healthcare are easy. It is the I don't say easy, but they're the easiest aspects of it. The social, the personalities involved, that's the hard part. I remember years ago when I was the medical director here in the city, we did a resuscitation in an individual's home, and they were asystolic, meaning they had no cardiac activity the entire 30-plus minutes that the fire department and the paramedics were resuscitating in the house. And so they were ready to stop, but the family was so upset because they hadn't shocked the heart yet. Well, if you're a clinical person, you know that no activity, a shock is not indicated, and the crew's calling me, and the family's upset because we didn't shock them. And I said, so shocking an asystolic heart's going to do what? What's going to do nothing? Is it going to hurt anything? And they said no. And I said, well, if it's for the family's comfort and so that they feel everything was done, then shock it. I mean, it's not going to change the outcome. It's not going to hurt anything, but they will feel that everything was done so they don't have hesitation and frustration. And so that's just a different approach. But we see those things frequently in medicine to where, no, it's not indicated, we're not going to do it. But we fail to look outside the clinical aspects of things and look at the interpersonal, the comfort of family, colleagues, nurses, as physicians. And to your point, Leanne, it was unique for me because I grew up as the EMT who was the paramedic, who was the nurse, who became the physician.
You're taking my question.
So still today, I was just in a meeting in Dallas with a big national group looking at, some really innovative healthcare stuff. And when I speak, I often view myself as that same, 17, 18-year-old kid on the ambulance. Although I'm not anymore. I wish I was still. But that's how I view things. And so it's kind of a unique view for me.
And that is very interesting. And to Leanne's point, I was going to point that out. You've worn several different hats in your healthcare career, right? Me, as an RN, if the physician says this is what we're doing, that's it. That's what we're doing. I applaud you, though, for asking the team, hey, what did we miss? And for encouraging that open communication. I think that is awesome. And I think that we need to see more of that. Because here's the thing. We all strive for perfection, right? But individual perfection is never attainable because we're humans and we are fallible and we're going to make mistakes. And that does include, unfortunately, physicians. And that's not a bad thing.
No, it's not. I mean, it's hard because we have the perception that there's a 0%, there's zero acceptable miss rate. But we all know that zero miss is unobtainable. And so, is there an acceptable number? Is there an acceptable number of errors nationally? 1%, 2%? I mean, nothing acceptable. But we need to have the understanding that things are going to go wrong. I mean, that's the whole theory of the root cause analysis, right? I mean, we often look at the individual when we have a bad outcome. But if you, for just culture as a prime example, right? You look at the system first. Is the system, did it set the individual up for an error, right? And so you have to look at the system. Human nature is to always look at the individual. But you have to take the individual in the concept of the entire system.
Correct.
Because I'm an emergency physician, worked at Parkland, trained at Parkland, worked at John Peter Smith, worked at some of the busiest places in the world. And you put me in a rural critical access hospital. No matter how much I know, the environment I'm working in affects my ability to do things. And so I think we often take that for granted because you can't compare the care or the system of a huge tertiary care facility that has 200,000, per year volume to a critical access hospital that has a doc, a nurse, and maybe a secretary who sees, a couple thousand patients a year. Regardless of the knowledge and the training of the providers, it just comes down to the system to support the infrastructure.
Couldn't agree more. And unfortunately, during this pandemic, there were several staff who would work in areas that they had the skills to be whatever their license, was, but But that environment, they weren't accustomed to. They didn't know where everything was. They didn't understand that. So great point. Let's pivot here just a little bit more broadly. And this is a big question. So according to the Commonwealth Fund, the U.S. spends 16.8% of our gross domestic product on health care. But yet in the U.S., we have the lowest outcomes. What one or two things would you suggest if you could say, hey, we need to do this, and it would start the path of transforming healthcare to more positive outcomes?
So we deal with this a lot. Ultimately, if you're a payer, then you look at the expend on emergency medicine and say, oh, it's astronomical. In fact, that's the meeting I was just in earlier. They showed 30% of healthcare dollars spent in emergency services. What I brought up is, first of all, how do you define that misuse, right? If I'm a payer, I'm retrospectively looking at a person that comes to the emergency department with chest pain, and after a thorough workup, I tell them they have a muscle strain. It's easy to make that call on the back end, not so much on the front end.
Amen.
But I think when you look at the healthcare spend and the cost it's the infrastructure, it's the system. Cost, but we really failed to look at how people get into that system. So if you're going to say 70% of people in the emergency department should have been somewhere else, the question is, okay, so why is the 70% there? I mean, why in the 911 world where I live, why do people call 911 for these low acuity complaints? Well, have you called your doctor's office lately? Have you called the pharmacy? I mean, what's the first thing on the recording, what it says?
If it's an emergency,
call 911. Well, so they're doing they don't know it's an emergency, but that's what the recording says.
And that's what it says on your discharge instructions,
Exactly. So they call it. So I think that the probably number one failure in this country is the primary care system is far behind the demand on the primary care system. We put out a lot of primary care physicians here at TCOM. That's not the standard in many medical schools. Most people look at that. That is a difficult lifestyle. It's not something you work 8 to 5 at and you go home and you disengage. The reimbursement system for primary care is hugely lacking, so there's really no incentive for people to get in. And so now you're seeing large healthcare systems investing in primary care and buying primary care clinics as a loss leader because they're not going to make money at primary care. But what happens is that's a referral network for them into their system to get, the colonoscopies or their, mammograms or whatever. And by the way, if you get hospitalized, then you're going to come to our hospital. And so, if I'm the emperor of the world, I think that's one of the things that really needs to change. I mean, I did some work in Havana in Cuba a few years ago, and their model is different, right? You get out of medical school and you're assigned a population. You get 1,000 lives. The government provides you a clinic, provides you the staff, provides you housing, provides you everything, and you own that, right? So there's no incentive or no deterrent for the model like we have here in the U.S. because it's a fee for service. Not all fee. I mean, they're trying to move away from that, but it's still primarily a fee for service. And so, if you go to the root cause of most things in healthcare, it is you reimburse me for doing something. They want to change that, but boy, that's a lot of money in healthcare, and unfortunately, most big players in the healthcare system are about their piece of the pie. And I know that sounds really horrible. And if you're a hospital administrator, please don't take this the wrong way. But
sure.
Right, I mean,
they're trying to keep the lights on.
They're trying to keep the lights on. They're trying to innovate, and they're trying to keep things moving. And they're measuring outcomes. But I've been in a lot of big hospital meetings, and the core measures and the outcomes are talked about, but they're not the focus of what they're talking about because it's become a business.
That's exactly right. And we do need to move to value-based care. Couldn't agree more, because fee-for-service, you're managing an episode of care, right? What's your investment in that patient?
So, Dr. Beeson, you mentioned earlier that you have worn many hats. You've been an EMT, a paramedic, an RN, a medical student when I met you, as well as a DO. Why did you choose this path?
I don't know that I chose it.
Why did this path choose you?
I remember I went back to the first question about planning. I'm not a planner. So I got into EMT training when I was in high school. So I was raised in a public safety world. My father was in law enforcement and an early EMS in the 60s in Texas and in the Vietnam era. He did some ambulance work in the old funeral homes before he was drafted and did it in the military. So I grew up in that environment. Really, all I ever wanted to do is be on an ambulance. And so I did that in high school. And then at the time, nobody in my family really ever gone to college. So my parents were like, you're going to go to college. And I'm like, I don't want to go to college. And so they didn't give me the option. So I thought, well, there's a nursing program there. It's only 2 years. I can, that kind of puts me on the same path of where I already love emergency medicine. I want to do things. And so I did, worked on the ambulance. I did nursing school in the daytime. I did back then it was called EMT Special Skills and then paramedic training. So it was all kind of simultaneously. I loved the work. I loved what I did. It was a family within a family. And so that's how I ended up there. And then ended up teaching. Worked at Tarrant County College, community college years ago as a paramedic instructor. Worked at Hughley and, worked at various jobs in ERs and ICUs, and literally I was going from job to job, but it was not a work for me. It was fun. And then, had the goal of wanted to get into flight medicine, and so was, obviously very lucky to get into it so early in my career. And worked for some great flight programs. Ultimately ended up in Houston working for Dr. Red Duke, was the big famous trauma surgeon that used to be on TV. And if you were in the flight nursing world, Life Flight was the place. It was the creme de la creme. And so worked there for years, learned a lot. Started was having a family, got married, obviously had our first one on the way, and was working on finishing a bachelor's degree, and didn't really know what I wanted to do, but I figured that I couldn't spend the rest of my life on these helicopters and ambulances and stuff. And then in July of '99, I had a catastrophic mechanical failure on one of the helicopters that I had gotten off of that morning time, and it ended up killing 3 of my friends. And that was kind of the decision tree of what else do I want to do in life. And so Dr. Duke was a great guidance, and I said, hey, if I wanted to go to medical school, what would I have to do? And that was kind of it. And literally looked at what I needed as far as the admissions into medical schools. Went down to Houston Community College, registered for those couple classes, went to half-price books and bought an MCAT review book and read it from cover to cover and took the MCAT and finished those classes and started medical school. It was literally – there was not a lot of thought or plan that went into it. It just happened.
And I remember you when.
That's right. And I was here. I came here. We could have stayed in Houston, come back home here to Fort Worth, could have gone out to California. And so my wife, we both grew up here in Fort Worth, and we moved back here. I was fortunate enough to work for Care Flight all through medical school. And so came up, they added a new base the summer before I started medical school. So I worked full-time for them, got the new base up and going, helped, and then went part-time and literally would be right here in this room. It used to be one of our study rooms that we're recording this at. And then I would go fly my night shifts at the Care Flight and come to medical school the next day, and that was it. I would like to say there was a lot of thought and plan that went into it, but it was absolutely the stars aligned and it just happened.
Yeah, but you were driven. You were driven because all those things you're talking about, everybody can't do.
I don't know that everybody can do. Yes, it was easier for me. And medicine is not easy for a lot of people. It's never easy for anybody. But to me, I'm a mechanical thought process kind of person, and as I have a barn out back of my house where I restore old vehicles. It's funny when I look at an engine that was produced in the 60s, and it's this almost the same components and systems to a body. And when you're able to do that analogy and understand it, it becomes a little easier. It's never easy, but
Okay, superhero, I have to ask you, what is your current role, and what inspires you in your current role?
Well, it depends on the day. So here at the Health Science Center, I work with under the Vice President of Clinical Operations and work collaboratively with, obviously, SaferCare Texas, work some with TCOM. Tarrant County College buys most of my time from the university, so I work with Tarrant County Community College District with the nurses and the wellness centers, and then their EMS educational programs. Outside of the university here, I work for a large national medical company called Global Medical Response. And so that is primary medical transportation, but obviously firefighting, and air medical, fixed-wing ambulances, helicopters. We're the FEMA contractor for ambulances throughout the country, so that's a big piece of what I do from the ambulance side. And then for fun is I do the Texas A&M Task Force. It's out of the TEACS, which is under Texas A&M system, the Urban Search and Rescue Team. And so that's kind of my fun on top of other things.
You are a mover and a shaker, aren't
Well,
you?
It is fun.
Well, I want to thank you for being here with us today, Dr. Beeson. I want to thank you for sharing your knowledge and your expertise. I also want to thank those that were listening today and encourage you to speak up for SaferCare. SaferCare Texas is a department within the Division of Clinical Innovation, and Speak Up for SaferCare is a product of our department. We'd like to thank our technical producer, Rob Upchurch, for helping us out with this podcast, and we encourage you, our listeners, to speak up. Advocate for yourself, your family, and your colleagues. If you're a healthcare worker, a counselor, subject matter expert, former patient, or a caregiver, and you have a patient safety story that you'd like to share, we'd like to hear from you. Be our next guest. Please contact us through our website, SaferCareTexas.org. Also, follow us on Facebook, Twitter, Instagram, and LinkedIn at SaferCare Texas. Thanks again for listening, and as always, speak up for SaferCare.